All right. Good morning, everyone. We are going to go ahead and get started here. So welcome everyone to our, oh, hang on, let me get my screen here. Well, looks like I can't control your mouse. Stop the screen share. Hold on. One moment. Having a few technical difficulties here. I promise it was working perfectly. Just a second. Let's see your screen sharing here. All right. Okay. I think we can go. All right. I think we're ready now. All right. Welcome everyone. This is it. Anyway, I just can't advance this slides. I think that was all. Oh, no. Okay. All right. I think hopefully this will be figured out for the rest of the day. All right. So welcome everyone to our virtual collaborative wide meeting here at MROQC. So just a few housekeeping items to start us off. So we will run just from 9 till 10:45. At 11, we will have a physician breakout. So make sure to stick around for that for those that want to attend. We will be recording the meeting and sharing the slides on the MROQC website for all members after the meeting. And for this meeting, we want to encourage some out loud questions. So we're not going to use the Q&A portion because it's very challenging. But we will allow people to ask your questions in the chat or raise your hand and we will unmute you so you can answer a question or ask a question in person. So for example, Danelle has her hand raised right now. Did you have a question, Danelle? Maybe we can unmute you. Is there a way to unmute? Well, a couple of people have their hands raised, and I'm wondering if they're if anyone's having trouble with audio, maybe. They need to put it in chat. I think they're just okay. Yeah. Sorry, not questions right now. Okay. During the late. Okay. Thought you could do this. Okay. Okay. And so we will be monitoring questions in the chat as well as raised hands. So today's agenda is going to cover, we're going to focus on prone positioning for breast, and then we're going to go through kind of our state of MROQC. Leadership will go over kind of our past and present, and then the working group updates will talk about current measures, how things are going, and planning for the future. And so without further ado, we will go ahead and move into the discussion on prone breast with Alex, Lori, and Frank. They're going to talk about the overview, setup considerations, and our utilization. So take it away.
Good morning, everyone. Thank you so much for joining us this morning. We are going to be discussing prone breast radiotherapy, specifically giving an overview, discussing some setup considerations, as well as utilization within MROQC.
We're not able to advance the slide. Here we go.
Okay, so we can start off with just giving an overview of breast radiotherapy positioning, as well as some immobilization considerations. So the most common treatment setup for breast RT is the supine treatment with arms up. And this provides quite a bit of flexibility when it comes to treating the whole breast, as well as any involved nodes. Even a two-field treatment is sometimes used to treat level 1 and 2 nodes. Additional fields can be added to treat the clavicular nodes as well as the IMNs. But this treatment has been very successful and has again provided quite a bit of flexibility when it comes to treating additional target sites. Breast conservation surgery plus radiotherapy has been shown to achieve the same outcome as mastectomy for both local control and survival. However, patients with large breast sizes who are treated supine have been known to experience increased rates of both acute toxicities, and some examples of those are breast pain, erythema, and moist desquamation, as well as chronic toxicities like fibrosis, retraction, and breast distortion that lead to forward cosmesis. Attempts to address these limitations have come in the form of the introduction of mixed energies to the treatment fields, mobilization devices that displays the breast from the chest wall, as well as modifying the patient treatment position. And we're going to be focusing on the latter of these two a little bit further. So just looking at a couple of immobilization devices, two common ones are the Chabner bra and the breast cup. The Chabner bra, shown on the left here, significantly reduces inframammary folds, which is an area of skin toxicity, common area of skin toxicity. It increases comfort and modesty, increases setup reproducibility with minimal skin toxicity. And a single institution study also showed that there were lower lung and heart doses as well when the Chabner bra is used for treatment. The breast cup, similar to the Chabner bra, reduces the inframammary folds. It could increase setup reproducibility and also increases the distance between the irradiated breast tissue and the heart. So as shown in the image, this is the breast cup here, and how it looks during the treatment plan is that it brings the breast tissue further away from organs at risk, such as the lung and heart. So this is the treated breast compared to the contralateral breast that does not have the breast cup. Are we having audio issues or are we okay to proceed? We'll continue on that. An example of a different treatment position is lateral decubitus. So this is shown in the top right image. And this treatment position can significantly decrease the breast separation. It reduces skin overlap in the inframammary fold as well. It introduces challenges, though, with day-to-day reproducibility. And can result in increased skin dose to patient due to treating through the table. Prone position is another option when it comes to modifying the patient's treatment position. And there are many options for prone breast boards. The fundamental concept is generally the same across all the available options. The differences between the different options will come in the form of patient comfort and treatment clearance. But the idea is that the patient lays prone with the treated breast laying in an opening that makes it accessible for treatment. So an example of the impact that prone has on the breast anatomy is shown on the bottom right images. So the left is a supine treatment, and we can see that the breast tissue lays laterally on the patient. This increases separation, and if the whole breast tissue is to be irradiated, part of that beam is going to go through the heart. If that same patient is simulated in the prone position, the breast anatomy drops further away from organs at risk, which could increase or reduce the likelihood of that treatment field going through organs at risk, again, like the lung and heart.
It's also a good example of how the separation significantly decreases when you put a patient in prone as opposed to the supine position.
Another benefit of prone is that it also eliminates skin overlap in the inframammary fold. However, if the breast is pendulous or significantly pendulous, it may puddle or pull on the table, increasing the challenges with reproducibility. So we're going to be transitioning over to some setup and imaging considerations for prone breast radiotherapy. And going forward, the rest of the discussion will be focused solely on prone. So some questions that often come up either at simulation or during treatment planning are some of the following. So can the patient tolerate or be comfortable enough to tolerate the setup for the duration of the treatment? When it comes to the treatment setup, is the patient leveled? Is there belly tissue that can impact how the patient lays and therefore impact the daily setup? Does the contralateral breast and how the contralateral breast lays on the board impact how the patient is laying on the prone board and therefore also impact daily setup? Are we able to treat the whole breast without treating through the treatment table? Is daily imaging necessary to assist with setup reproducibility? Are there options, technological options like surface monitoring that is needed for setup and intrafraction monitoring? Or finally, is there puddling or pooling on the treated breast that needs to be addressed? We're going to be looking at, we can spend a long time discussing each of these points, but today we're going to be focusing on the latter three and looking at each of these individually a little bit more. So is daily imaging necessary to assist with setup reproducibility? Depending on the patient population or the experience of the treatment team, unique imaging protocols may be required to verify patient setup reproducibility. Again, this can vary from imaging weekly or imaging every day. An example of a daily imaging protocol is shown below. So on day 1, KV-APPA images are acquired to verify the lateral offset of the patient. And the patient is repositioned if they are offset by more than 2 centimeters. Also on day 1, 2 lateral KV images are acquired. The first uses an imaging technique to visualize the chest wall in order to verify the patient's depth or vertical positioning. The second image is used to visualize soft tissue in relationship to the body contour. And when necessary, the soft tissue is manipulated and the couch is not shifted greater than 5 millimeters. On day 2 through end of treatment, only tangent images are required to ensure that the soft tissue is aligned within the body contour. And the breast anatomy may be manipulated and placed in the appropriate position as long as it does not exceed the half a centimeter tolerance. If that exceeds half a centimeter, then we can revert to day 1 to verify that the patient's depth and laterality is appropriate, or lateral positioning. If the couch position is flagged by the software, acquire another KV-APPA image to verify the patient's lateral offset on the prone insert. And the patient is repositioned if the shift is greater than 2 centimeters. So again, this is an example of a daily imaging protocol, but something like this with modified tolerances can be used for patient setup reproducibility, as well as aligning the patient daily. The next question that often comes up, is there surface monitoring needed for setup and intrafraction monitoring? So there are technologies like Align RT that may be used to assist with patient setup and motion monitoring during treatment. What you see on the right is an example of guidelines provided by Vision RT, which is the vendor for Align RT, on how to contour the surface of prone patients. So they suggest to include the breast tissue and ipsilateral and contralateral shoulder, including the scapula, and do not include the arms or upper shoulder because of day-to-day variability in these anatomical regions that can increase the uncertainty of the Align RT setup. So this is another example of technologies that can be used to increase the setup reproducibility of prone treatments. This is not a common use of additional technology, however. And the final question here, is there puddling or pooling of the treated breast? So all patients are simulated on the prone breast port, which can either come in this form, which has risers that support the patient, or as a table insert shown here. The table insert is dedicated for treatment only, not for simulation. However, at treatment, the breast could just be suspended, or it could puddle on the table. If it does not puddle on the table, this is great. The patient can be treated on the floating prone insert, and that means that for treatment, you have a little bit more clearance and beam angle options. If the patient puddles on the table, then they will have to be treated exactly the same, using the same setup that was done at the sim with the risers. They can no longer be suspended on the prone breast insert. And this image on the right shows how a breast that puddles look during treatment planning. So how do certain clinics handle this? So this is an example of the additional steps that are taken during a prone simulation when the breast puddles. So there is the skin marks that are standard for all prone, but then the breast is outlined on a template or a sheet of paper. And this image on the right shows a closer look at how that the breast is outlined on the sheet of paper. And then there are additional marks drawn that indexes that paper or template to the table itself. And then that template is further abutting the upper risers of the prone setup. And again, this is all in place to increase reproducibility at the day of treatment and every fraction thereafter. So it's additional work, additional steps, additional indexing parameters that need to be properly documented if accurate treatment positioning is to be achieved every single day. So now we're going to transition to the impact of prone utilization on cardiac sparing within MROQC. So we discussed that patients with large breast sizes were known to experience increased rates of both acute toxicities and chronic toxicities that resulted in poor cosmesis. Prone setup was used to address those issues and limitations with the supine treatment. But prone setups were also quickly found to reduce dose of cardiac structures and lung in most patients. So a retrospective investigation was initiated within MROQC with the goal of investigating the impact of patient and treatment characteristics on achieving a retrospectively applied conservative mean heart dose and lumpectomy planning target volume coverage metric. So this is again achieved through retrospectively applying these mean heart dose and PTV coverage metric to patients treated within the consortium and assessing what percentage of patients would have been compliant with those metrics. The covariates of interest for this retrospective analysis were breast size, heart size, breast separation, age, body mass index, and treatment position. And for treatment position, we're focusing on supine with motion management, and prone. Motion management was defined as patients treated with a breath hold device, such as ABC, SDX, or a gating device such as RPM or Align RT. The patient split for motion management were about half and half. So 47% had motion management and about 53% had no motion management. And then for treatment positions, 76% were treated supine and 24% were treated prone. Again, the performance metrics that we are looking at are a PTV coverage metric, defined as at least 95% of the lumpectomy PTV receiving at least 95% of the prescription dose from the whole breast plan. The mean heart dose is defined as the heart receiving a mean dose of 1 gray or less from the whole breast plan. And the composite metric is meeting both the lumpectomy PTV coverage and the mean heart dose metric. There were 2,492 patients in this retrospective analysis. All of those patients were treated between 2018 and 2022. All had moderate hypofrac with daily fractionations ranging from 2.5 to 2.8 gray per fraction. All patients were left-sided cases, and they were all node negative. If there was a boost plan present in the patient's treatment course, the boost plan was excluded from the analysis. And the final criteria is that all planning structures needed to be TG 263 compliant. So this is the breakdown of the breast volume. So there were 4 quartiles that were introduced. Quartile 1 were patients with breast sizes less than 720 cc's. Quartile 2 was 720 to about 1065 cc's. Quartile 3 was 1065 to about 1500, and quartile 4 was about 1500 cc's. All quartiles had roughly the same number of patients. So we're going to be looking at 2 figures here. And initially, we're going to be focusing on figure A on the left. The x-axis has the different breast size quartiles, which are shown here again for reference. But quartile 1 consists of patients with the smallest breast sizes, and quartile 4 consists of patients with the largest breast sizes. The y-axis is the percent compliance, so the number or the number of patients, percent number of patients that meet the different metrics of interest. The black bars show the composite metric, meaning these are the number of patients or the rate of number of patients that met both the mean heart dose and the PTV coverage metric. The hashed bar is just for the mean heart dose, and the white bar is for the PTV coverage metric. What we're seeing here is that patients with smaller breast volumes tend to have a higher likelihood to be able to meet the mean heart dose metric, as well as the PTV coverage metric, and the composite metric as well. And these values tend to decrease as you increase breast sizes, except for the PTV coverage metric. That remains relatively unchanged regardless of breast size. If we focus solely on the mean heart dose metric, since that is what is driving the decrease in compliance rates, again, the y-axis is percent compliance, x-axis is the breast size quartiles, with Q1 having the smallest breast sizes, and it increases towards Q4, which has the largest breast sizes. Here we are looking at treatment position combined with motion monitoring. So the black bars are supine treatments without motion management. The hashed bars are supine treatments with motion management, and the white bars are prone treatments. And we see that a couple things to take away. As you increase breast sizes, the compliance with the mean heart dose does decrease. However, prone outperforms supine with or without motion management quite significantly, and it is more drastic in patients with larger breast sizes. Supine motion management, supine with motion management is a good technique that does outperform supine without motion management, but it is not as good as prone when it comes to meeting the mean heart dose metric within this patient population. We are honing in even further into the data set here. So we're looking at both the mean heart dose metric only, and now we're focusing on patients with very large breast sizes, defined as those having breast sizes of 2,000 cc or more. And we see the same trend where prone positioning significantly increases the likelihood of being compliant with a conservative mean heart dose metric of 1 greater or less, followed by supine with motion management, and then finally supine without motion management having the lowest compliance rates. This figure here shows the different covariates and the odds ratio, or the likelihood of being compliant or non-compliant with the mean heart dose metric. Compliance is indicated by a point further to the right, and non-compliance is indicated by a point further to the left. At a glance, we can see that age group does not significantly impact compliance, neither does BMI. Breast size does not impact compliance up until you get to very large heart sizes. So 690.1 cc or greater heart was trending towards increasing compliance with the mean heart dose. And then breast size decreased, or rather trended towards non-compliance. And as the breast size increased from 720 cc and the second quartile to over 1500 cc in the fourth quartile. Non-compliance increased as well. Breast separation did not impact compliance significantly. And finally, treatment position, as indicated within the prior slides, supine with motion management increased compliance, and prone increased compliance even to a greater degree. And these are the references that were cited in the slides as well. And we can transition into our Q&A.
Great job. All right, well, I guess there were some questions that have already been submitted. And I'll just say that one of the main reasons that Alex gave this presentation was that we know that many of you who are not part of the breast working group were asking questions about prone positioning, because this is a metric that is consortium wide. So we thought to talk about it now and to have interactive discussion with members of the consortium would be very helpful. Actually, I don't know if we want to start with our questions. I see we have why don't we start with the questions and then we'll get to, these were already submitted. Our facility only treats patients with SBRT supine. Can this be added to the listed exclusions?
It's a little tough because
SBRT.
right, and it's a facility specific limitation. We don't have any data that kind of shows how SBRT performs with respect to cardiac toxicity. But we do know that prone is really good.
And also SBRT is only going to apply to a really, really small percent for breast patients. We're talking about whole breast or partial breast. And I would assume this would only be relevant in the partial breast. So in addition to your thoughts, I mean, I think the absolute magnitude of this wouldn't be a problem. And we have to remember that the highest level is 30% in terms of our points. So there's a lot of latitude.
But, and then this is, so all breast patients that come through this facility, they're only treated with SBRT.
I think they were saying our facility only treats patients with SBRT supine. So for those who get SBRT, it's only done supine. I think that's what they meant.
Okay.
Right,
Yeah.
which is that it's a really small percent.
Right.
You're talking about breast cancer, definitive breast cancer following breast conserving surgery. So it's going to, I assume it only would apply to partial breast, if at all.
Right, which in that case, it should not be listed as an exclusion criteria.
Correct. Right. That's right. Really, really small. Trick question.
It is.
Frank, you want to take a second?
Yeah, sure. The question is, DIBH has also been shown to effectively reduce heart doses. So our physicians often use DIBH for left breast cancers. Could DIBH be added as an exclusion? You know, I've kind of come full circle on this. I mean, having been involved with the initial studies to use the active breathing control device to treat left-sided breast cancer, to spare the heart, you know, our clinic was geared towards doing DIBH. But now, having seen a little more practice with the prone positioning, I can tell you that based upon Alex's data showing that it's actually better in some cases than DIBH. And also DIBH takes longer to treat the patient. And that's kind of a difficult thing in our clinic. And it's more difficult on patients, I think, than the prone positioning. So even though you're taking into consideration cardiac sparing by using the DIBH, I don't think it should be used as an exclusion. I don't know what you think, Artie.
No, I agree. And again, when we talked about this as a working group, the breast working group, and we thought that having 30% gave a lot of latitude so that people wouldn't have to make dramatic changes. If you got very good heart sparing with deep inspiration breath hold, and if you want to do that, that was fine. You still could then use prone for other patients. But I think an important point with this is that obviously heart sparing must be first and foremost on your mind when you're planning these cases. And two, as a part of this metric, we're asking physicians to write down why they chose what they did. So that this was a great suggestion from one of our members at MROC. And I think that will give us some feedback for why people are doing what they're doing. But I would not put it as an exclusion. I think it is a tool that certainly can be used. But as Alex showed very nicely in the data, even when you look at patients who have some type of motion management, you get even better heart sparing for most patients with prone. So I think this is a learning. We will learn a lot from people's experiences.
Absolutely.
Yeah, and there are some patients that may not be able to tolerate the IBH, for which
Yeah.
prone might be a good option.
I'm glad you brought that up. It's actually one of the questions that you listed that we didn't go back and talk about, or how do people tolerate prone? And I'll give in my experience, I'll be very interested, Frank, for yours, is that you have to get a person used to it at time of sim. But for the patients that I've done with maybe one exception, once they've gotten used to it, they've actually said, oh, this has actually been easy. So it's like anything else. Once they have done this, it has been easy for them to do, and if done correctly, as Alex said, it's been reproducible. Frank, what have you
The
found?
same experience.
Right.
As I mentioned, the IBH, I think it's harder with ABC device than it is prone. And so the patient can tolerate prone, going towards that direction lately.
Yeah.
I think that one.
If the breast is not pendulous, our sim therapist and physician use their judgment to determine whether a patient is a good candidate for prone position. Could physician preferences be added as an exclusion? So our data shows a broad range of breast sizes. And one can deduce that the smaller quartile or smaller breast patients are not as pendulous as those in the higher breast sizes. But across the board, all breast sizes benefited from prone positioning over supine with motion management or supine without motion management. So I think it should not be included as an exclusion criteria. And so that's the first, I guess, justification. The second one is that we already have a cutoff for breast size included as an exclusion criteria. That already would account for patients with smaller breast sizes that would not be as pendulous as slightly larger breast sizes.
Right. I add, physician preference, physician judgment should always be an important part of patient management. And if the physician or the team feels that that patient's not a good candidate for prone, you absolutely then should treat them supine with motion management. And so again, that flexibility is there given the system that we've set up with the cutoff being 30%, and to reflect that it was the judgment of the team that the patient would be better served for whatever reason, X, Y, Z, should be listed on that form. Again, so we capture information and we can share it with the group after the first year of this metric. But I would always go with your gut. If you think that that patient is better served by a physician that's not prone, then absolutely don't do that. I don't know, Frank?
Yeah, I agree totally.
I'll take the next one. Can B cups be added to the definition of small breasts? So we had the working group, we had these discussions, and it's very hard when you're talking about A cup, B cup, C cup, for it to get objectivity with that. So we thought, looking at prior studies done elsewhere, that we should come up with an absolute size. And so we came up with 1,000 cc's. you know, it's a small breast, medium breast, large breast. And I mean, it's certainly a continuum along that. And we thought that very small breasts would not be good candidates, very large breasts would be, and it's that middle group, and that's what you're asking about here. And I think that's where it comes to the judgment of the physician or the team. And if you think that that size, the patient has a size breast that would be better served by a supine physician with motion management, do that and then list that on that form. Again, we are very much in a data capturing learning mode. Excellent suggestion from a member of the consortium, and I think we'll be able to discuss this going forward with data. I don't know, others, thoughts?
Just a learning experience.
Yep. Yep.
I can take the next one. It says APBI is not eligible for prone, so can this be added as an exclusion? Well, APBI is eligible for prone, but there's actually large experiences published with. I think it's the question where the cavity is in relationship to the chest wall for PBI, whether or not prone is better or not. So I really don't think PBI should be used as an exclusion. I don't know, Lori.
Yeah, no, I agree. As we're all getting more experience, Dr. Vicini has a ton of experience, because we're all getting more experience with PBI. I think there's some patients who are treated very well with that prone. So it's a judgment thing.
Okay. The last question, right-sided breast patients, can these be added as exclusion? So for right-sided cases, the cardiac structures are not a concern, as big of a concern, but there's still.
Occasionally.
Yeah, like you said, not as much, because sometimes it's surprising. Yeah.
But there are other benefits to prone, such as decreasing breast separation and eliminating the inframammary folds that can result in greater toxicities. I'll honestly split about this one.
About whether she be excluded.
Right.
No, I think, as you said, that for certain size breasts, it's still the dose and homogeneity that you want to minimize so that you don't have toxicity, both acute and chronic. So right side breasts can be as big as left side breasts, obviously. And so while the cardiac concern is not generally a major concern for those who have right-sided lesions, the breast size and the issues associated with that, and then there may be some lung issues that, depending upon the contour of the chest wall and how the lung fits in, that perhaps that would be lessened by prone. But I think most likely it's the size of the breast and the dose of homogeneity that would guide you for right-sided. So again, plenty of room to make that decision and to decide whether to use prone or not. All right, great questions. I must say these questions really all focus almost all exclusions, and it's almost, I think part of this is we're all trying to learn how best to use prone, and there may be some resistance, but I hope as more institutions use it more, that you will see the positives of prone positioning, because from a patient perspective, it's generally very well tolerated. All right, I know we've got questions. So how
Yes.
do we bring up the questions?
So I am going to let Dr. Fetterman, who has been patiently waiting with his hand raised, I'm going to unmute him, and then he can ask his.
Mark, are you there?
Is my speaker working? I had some
Yeah,
connection.
yeah, we got you now. Hey, Mark.
You're on.
Hi, great. Yeah, I didn't interrupt earlier on a comment that I have some pretty strong feelings about. And the bigger point is the second one that's tied to it. I don't still understand what the issue is with being opposed to daily imaging on such a high-risk variable setup. We obsess with the precision on how we do breast treatment. We're obviously getting more relaxed now for protecting heart tissue compared to competing all breast tissue, but it's very easy, very quick, very low cost, relatively speaking, to the treatment to do the daily imaging. And if we don't do it right, and there's a lot of potential variability, a millimeter roll can cause a difference. The biggest issue not mentioned earlier is how do we compress these large breasted women's opposite breast? And if that's going to be pushed differently one day or another. So I think our techs are good and do a great job at doing it, but imaging gives them increased security. But the correlated that I didn't hear on your protocol is we're doing cone beam CT scan in all these patients. because we've had more than one patient actually show breast reaction earlier on a few years ago on the contralateral breast, and re-looked at it and realized that the most reliable way to do it was cone beam CT scan. And I had a patient just this past week that looked like a very good plan, but a newer dosimetrist. And when I very carefully looked at it, I realized there was a lot of possibility with a very small variation of that opposite large breast being compressed on the opposite side, rolling into the field, and had to change the plan for it. So our protocol is to use cone beam CT scan for all these patients. And I think even considering not doing daily imaging for this is problematic. They can't see what's going on with this breast very well. We can't see what's happening on the other side. So thanks.
Yeah, that's a great comment, and that's been kind of my experience as well, working with our therapist and learning about what their concerns are. And yes, we also use daily imaging by default. We do also rely on our physicians to kind of guide us as to which patients that is just not appropriate for. But we completely agree that gives our therapists a significant boost in confidence in knowing that the target is where it should be. And we're also experiencing tons of variability introduced by the contralateral breast for larger patients, excess tissue in the belly area, arm positioning that's not may not be reproducible, even with a wing bag on a daily basis. These are things that are mitigated by daily imaging, and again, give our therapists a significant boost.
So Mark, I'm going to play devil's advocate here. What you said absolutely is right. For a large breasted patient who also has a large contralateral breast and there are setup concerns. Let's just say that as we've become more comfortable using prone, we continue to see, based on our data, that we're using it for smaller breasted patients. So let's say that moderate sized breasted patient, where the opposite breast is not an issue, setup is beautiful. Would you still mandate that person be imaged daily, given the dose of radiation going to other parts of the body that wouldn't necessarily have to be done if her setup has been shown to be reproducible?
Am I still muted or not?
No, you're there. We can hear you.
I see no sign on my screen where it is. I would still strongly favor it, because we all know from experience in our supine setups as well that very small position setups can lead to very large changes. Whether it be the arm that we're not imaging with a line RT, which we do use, by the way, for this also, it has been helpful. Just a very small arm change can cause a positional coverage. And obviously we're building in margin, and we have competent techs that are doing it and very skilled at what they do, but it's a very easy thing to check on it. The issue with the smaller breast women going prone, which is a smaller grouping, then the issue is not going to be so much the contralateral breast, which I'm really worried about each time getting radiation dose when we would want to give it there. Then I'm worried about the roll effect and or other position changes that we might have more tolerance on. But if the whole issue is to be protecting normal tissue, we might be moving it. So I've heard numerous presentations from NCCN and other academics on why we don't need to do daily imaging for breasts. And I'm not convinced of it. And I think that the arguments I made for the large breast is because of that particularly horrible situation I'm seeing or afraid of seeing. But you can make the same argument for each of the scenarios we're doing in the prone position. And for that, fine.
So on that, we will agree to disagree, because I must say, for a smaller breasted patient, I'm talking about the middle-sized patient, middle-sized breast. If I have gotten to the point where I am confident that their setup is correct, I would not really want to expose them again to. We're giving mega doses of radiation to the treated breast, but other areas that I would worry about unnecessarily exposing them to low dose radiation. So I think it's a great question. And I think this back and forth shows a lot that what we need to learn about this. But the first and foremost, we got to make sure that what we're treating is being treated correct. And if you don't feel that's being done, then daily imaging absolutely is what is necessary. I think it's only if you've been given that sense of security that it's going well, that perhaps you can reconsider that. But it's,
a corollary to that, by the way, which isn't imaging, but it ties into this topic of the setup, was referred to earlier, and that's the abdominal roll. And that's actually been a limiting factor for some of the patients for me using prone, has been if the woman has large body habitus on their belly, then it becomes a problem too. And also another area to look at. So just as additional factor on that.
I know we've got a lot of questions. We're running late, so we'll go on. Thanks, Mark. Thanks,
Sure.
Mark.
All right, I'm going back up to the top. Sorry. Oops, slides are moving.
I know.
Okay.
We'll make it
All
up later. Okay.
Okay, don't worry, we'll make it up. Yes, Larry's right. I was actually starting to worry that we were going to have a lot of time, so I'm glad people put questions in. So, first question after Dr. Fireman had raised his hand, was, you know, to those of you on the panel, can you give some advice on how to get the treatment team, especially the therapists, to embrace Crohn?
So I think, at least my opinion is that the therapy profession is very hands-on, and from what I've gauged with my interaction with them, they feel more confident and comfortable with treatment techniques that they've practiced quite a bit. You know, at some point there needs to be a starting point. But one cool thing about MROC is that we know which facilities are doing Crohn, and we can just do a knowledge transfer session. My clinic is more than happy to host individuals that are interested in seeing Crohn setup in action, both during SIM and treatment, so that a group of therapists can at least perform a dry run. So that's another example, or an example of how they can get more comfortable with that particular treatment. It is not a simple treatment. The benefits are significant, but the setup itself is not simple. Others may disagree, but I consider it a very, very difficult setup. I don't know if that answered the question.
You know, I will say, I think it's a great question. If the physicians want to use Crohn, and hopefully they kind of set the tone, I think MROC would be a wonderful way of being able to work with, as Alex said, to have people to come visit for institutions that do it, so they can see. And then maybe similar to the lung work group, at one point they did a roadshow for motion management, that we could then come to those institutions, so that there would be that transfer of knowledge. So I think MROC would be a great way of doing that, right?
So looking through a lot of the other ones, I feel like we have a lot of comments versus questions. Good comments though. And I think and you all correct me if I'm wrong. Some of it got brought up when Dr. Fireman was speaking and some stuff. And I can see Ian. You guys can't see Ian. I can see you nodding his head. This is the power of being the host of the webinar. There is one question, and I'm actually happy to take this one. And so it comes from Dr. Kaufman up at McLaren Northern, and that's about, you know, so their clinic is close to 100% compliance with heart dose using deep inhalation breath hold. And the patient population that they serve who would benefit from prone position would be small. And so he's asking, how do we justify to our hospital the capital investment to purchase a prone board? And so for those who aren't aware and not active on the working group, there are 5 facilities in MROC that are currently do not have prone capabilities because they do not have a prone board. I want to actually give a huge shout out to a member of our executive committee who is an administrator with the Henry Ford Providence, the east side Henry Fords, and that's Karen Roskowski. And Karen has been working with me to kind of help on a few things with getting some boards. And actually Karen made my morning because she sent me an email this morning saying that 2 of the facilities that we were trying to help are going to be able to purchase boards. And we're working on helping the other facilities. So if you are a facility that does not have a board, we are happy to help you. I know that there's a couple in the McLaren system, and so I have been working with someone over there trying to help. But that, you know, totally understand that, but we definitely are here to help from the coordinating center standpoint as much as we can. We do have one question. Does anyone have data showing that prone treatments are faster than deep inhalation breath hold treatments on average?
There's data. I'm just going anecdotally on some patients with at least the ABC device for left side. In many cases, I've seen in my own experience, prone is easier, quicker, but that's a generalization. I'm sure it can be just the same in some cases.
But we also do, how many cases you've been prone? I mean, it's a learning curve.
Yeah,
And,
that's true, yeah.
When
Yeah.
you've done quite a few, if you asked,
Yeah.
you asked Sylvia Fermente, who
Yeah.
was one of the queen of prones, she would say just like
Right.
that, but then they do so many prones. So part of that has to do with, I think, with your use, your frequent use of prone.
And then is that question also just the delivery time or setup plus delivery time?
I'm assuming it's the whole thing. So yes,
Yeah.
yes.
Yeah, treatment team experience could impact that significantly, as well as the imaging protocol. If there's daily imaging involved, that adds time. If they're treating a prone patient a month, that also adds time because there's a lot of time in between each of those treatments. Yeah, a lot of variables.
Yeah, again, they're generalizations. The physician can decide which technique is best for their patient. We're just trying to push the idea that many more patients are probably candidates for prone. I can tell you my experience, I've adjusted it through the years, more prone lately. And I'm glad that MROC is pushing it, to be honest with you.
Yeah. I will say the same thing. I did not utilize prone frequently at all, and I'm doing it more, and I'm not sure why it's taking me so long to do this, to come on board, because I'm seeing more and more positives. But again, it's just my getting used to it and our institution.
Yeah.
I mean, some of the therapists, I mean, it takes time to get used to it, but I'm already seeing that they're saying, oh, good, we have another prone patient, for some, oh, we're doing, so it's flipped now, in
As
the other
opposed to
direction.
why are you doing
Exactly.
that?
Are you sure, Dr. Pierce, you want to do this person prone? Right, actually, I know we're running out of time, we've run out of time, but there seems to be a lot of questions about partial breast IMRT. And I think we need to look at that because I'm seeing a lot on that. Alex, do you want to?
And Dr. Bergsma had a good question, but it would require the coordinating center to run some data. So
Yeah.
it sounds like we know what we need to talk about at upcoming working group calls. We need
That's a good point.
Yeah.
Made.
Can we just can you just address the IMRT and whether you can do a prone patient using IMRT? Because there seems to be a feeling that doesn't work well.
Yes, you certainly can do treat prone with IMRT. A common one, as we discussed earlier, is treating prone APBI with IMRT. And that an indication for that it would be if the breast is very pendulous and has a large separation if treated supine, and having to treat that with APBI would not generate a good looking plan. It would be significantly better to treat a pendulous pendulous breast patient prone if PBI is the treatment intent.
Sounds like it'll be a discussion point in the working group. And then one last thing I saw, had a note about medial lesions and prone. And it may be that the position of that lesion, especially if it's closer to the chest wall, that prone is not a good option. And so in that particular patient, you would note, I've treated this person supine with motion management because prone would not give a good, and so note that on that form. Because I agree with you. First and foremost, you gotta make sure you gotta treat the target, treat it correctly. And if you have a medial lesion that's close to a chest wall, prone is not the right choice for you there. Right, so good point. Okay. These are some, we do have a lot to take back to. This is great discussion, and thank you for comments. This is fabulous. Thank you,
Alright.
everyone.
Thank you. So Frank and Alex, you can go relax for a second, while Bob and Martha enter the room.
Magic of filming. Now I've got 2 more people. So this part of the meeting, we're going to talk about the state of MROC, past and present. And we thought it was time to kind of just do a quick look back, examine where we are for those working groups that you may not be a frequent member of. You can kind of see what's going on. And then we want to tee up the conversation for then the breakout for the physicians and administrators to follow to talk about strategies for where we go in the future. So we'll do past and present now, and please start thinking about future directions for MROC. Fantastic. So I'm not sure how many of you may have been at that meeting in 2010. Blue Cross and Blue Shield of Michigan convened a meeting of many of the breast radiation oncologists in the state of Michigan in 2010, because they were noticing this thing called IMRT. And they were noticing the reimbursement, the cost of IMRT, and they were noticing how much more expensive it was compared to 3D. And so they wanted to kind of bring together many of the institutions across the state who were using or not using IMRT. And it became very clear to them in that meeting that there was a range, that there were some institutions that were using it for almost all of their early stage breast patients. There were some that were hardly using it at all. And, you know, it was an interesting experience. I think Dr. Frank Puccini was there, I was there, and there may have been other members who are currently at MROC who were there as well. And it became obvious to Blue Cross and Blue Shield that this was something that needed to be addressed, whether IMRT was really necessary for breast. And then they also said, and for lung too. We're starting to notice it for lung, but really for breast, this is the issue. And they then said, could we possibly have a meeting of the minds through something called CQI, which in radiation oncology did not exist, but existed for other disciplines. But maybe it was time to consider a radiation oncology CQI to address this question of IMRT. And then, oh, by the way, if you do that, then maybe you can also do some quality initiatives. That's what led to the start of it. And so 4 institutions, obviously including Michigan, began to start putting this. Michigan is the coordinating center, but there were 3 other institutions that were at the ground level for MROC. And we started in 2010, but it really got going in 2011. So since 2011, MROC has been a platform for both comparative effectiveness research and quality improvement. And this work, as you know, has allowed us to move the needle in a positive direction with clinically meaningful endpoints. Everything we do is clinically meaningful for our patients. And our success in breast and lung cancers, which is how we started, has allowed us to expand to patients who have bone metastasis and prostate cancer. And so that, in a nutshell, is why it's.
And so if you look at how we have evolved, we have a mission, we have a vision, and we have values. Our mission is to improve the quality of radiation therapy through patient-centered care. Again, our North Star are our patients and the needs of our patients. Our vision is to expand access to high-value care. Our values are patient-centered care. Again, we all focus on the patient. We all come back to what the patient needs. Evidence-based care. These are not whims. We do this based on the evidence. And there has to be collaboration, and there must be respect. And our goals: deliver equitable care. Every patient deserves high quality, equitable care. And we do so by standardizing treatment planning and delivery techniques, developing best practices, guiding the appropriate use of our high cost technology. What we do costs a lot of money. It's worth a lot, but we have to make sure that we are being judicious in our resources and how we use our resources. Sustained growth. And then our data helps to inform policies, helps Blue Cross and Blue Shield of Michigan to inform their policies.
So whenever I'm at conferences or talking to people in other states or other countries, they ask, what is MROQ? Tell me a little bit about MROQ. I've seen the same thing with Lori and Martha talking to people. And sometimes you really have to zoom out and take a look at our MROQ structure. We all live and breathe MROQ every day. It becomes sort of common knowledge and common discussion for amongst ourselves. But when you zoom out like this and realize that we have over 300 members, we have a large, diverse, well-representative executive committee. We now have 5 quality working groups and committees. We have this being one of our 3 collaborative-wide meetings per year, with 2 of those being in person, and a coordinating center here, which a picture is worth 1,000 words. I think we can see the coordinating center, or at least a large amount of folks here in this picture. And the way I describe it, or certainly perhaps the way that I've seen Lori describe it, is that we're here to serve the state and to serve our members and to serve our patients. And so this is a large group that works well together, that happens to be called the coordinating center team, but I would really describe it as the team that works on behalf of the patients in the state that are getting radiation therapy. And then what I think we've all realized over the last 14 or 15 years is that by providing this good care and the model of quality in the state, that those things have translated into a voice for the national and international community. So it's something that I think this picture is something that I certainly am proud of being a part of and in. And then I think you can see who we serve or how we serve visually here across the state of Michigan. And I don't think the diamonds here, I just came from skiing, so I think diamonds are on my mind, but I don't think that they show really the large circles that those diamonds serve. And so I think that if you look at sort of the overlap of the patients served by each one of the centers that are on the call, that you really have a Venn diagram overlap of the entire state. So that is sort of, I think, my view or our view from above as we describe MROQ to others.
All right, so when we decided to split these up, I, as a physicist, got the numbers slide.
Even though I did say that we as clinicians could have handled this slide.
Yeah. But really, I mean, these numbers represent the, amazing number of patients that have been served by MROQ at all of your institutions. And we are just here to support that. I think it's really incredible when we're talking about MROQ to just the sheer size of our patient data set now that we can learn from and help future patients is just incredible. So we have over 25,000 breast patients, 6,000 lung patients, approaching 5,000 bone mets patients, when that is a brand new project, or it feels brand new. And then now we're at almost 4,000 prostate patients. And so, as Bob mentioned, we have 5 quality improvement working groups: breast, lung, bone mets, prostate, and now our newly renamed M-Equal committee. And we're all, these are all representing a huge membership within MROQ, multiple different roles that people play on these committees, and your input on these committees is what really drives the quality projects that we're doing. And so we really appreciate everyone's input and contributions to these, because this is where I think the real work happens, is in these committee meetings. So we've had a number of notable achievements, and Bob and Lori can, chime in on these. Increased use of accelerated whole breast, decrease in radiation dose to the heart for lung cancer patients, use of shorter treatment courses in bone mets, 70% rate of collection of pretreatment prostate patient-reported outcomes. These are all just a tiny sample of the work that we've done. I don't know if you guys want to talk about kind of some of your favorite achievements.
So I'll just add, with regard to the breast increased use of accelerated whole breast radiation, obviously the way of the world has been to increase the use of short course treatments. But we have shown in previous presentations that the uptake in MROC was far more, was earlier and greater than what was happening generally across the country. So there's no question that we were some of the early adopters in the US for short course whole breast treatment, in part because of MROC. And then with regard to the decreasing dose to the heart, and then I certainly will defer to my colleagues in lung, and to Bob's done a lot of work, even though he's not a lung cancer person. I did a lot of work with lung. We've also done a lot in breast, and as everyone knows, so many of the metrics over the years have been focused on maintaining excellent tumor coverage, or tumor bed coverage, while also minimizing dose to the heart. And the reduction to that low doses and the ability to do it, MROC is unparalleled for breast cancer, how low the doses have been. So kudos to you.
I know for lung, one of my favorite projects was increasing the rate of motion management. I think we had done site visits across the state, and it was,
I was talking about.
yeah. That was, I think, a very meaningful project for the state. For me personally, I think it was one of the first big projects that I did within MROC when I joined. And I think making those connections is really valuable, and we saw it in the data. And also that we've sustained that high rate of motion management even beyond having it as a performance metric, which I think is a really great indicator of quality and the value that the work that we're doing brings to patients.
Yeah, when I reflect on these, I guess as to set up a framework of thinking for each of the individual work groups, and also as we go into the breakouts, is that I think largely these, with the exception, I think, of the first challenge or charge for the foundation of MROC, there was some questions from Blue Cross Blue Shield, but largely these are things that we generate the data, we have the pulse ourselves, and these are goals and improvements that are organic and come from our members. And so I think as we sort of set up what we're going to talk about for the next hour, and then what we're going to talk about in the breakout, and then for the rest of the year, just to recognize that I think our best ideas come from our consortium. And so our whole idea of talking about the past and the present is not so much to celebrate, although there is reasons to celebrate, it's more as a motivation to continue to do what we're doing.
So these are just some of our ongoing initiatives. So emphasizing shorter courses of treatment, which are effective across different body sites, which we had mentioned within breast cancer previously, but this is also something that we see in other areas as well. Continuing to reduce heart dose for breast and lung cancer patients. We've also had an ongoing project to reduce esophageal dose based on dose metrics that have come from our own data, which I think is amazing. Our M-Equal committee is committed to addressing disparities in treatment delivery and working with other groups in the CQI platform to do this. M-Shield is an example of one of those. I don't know, Bob, do you want to mention the
I think one of the stated goals of us, as well as in conjunction with Blue Cross Blue Shield, is just work together and collect data across collaboratives. And that's really one of the things that prostate cancer and the prostate working group has been able to do. And I think it's areas that we'll continue to look for opportunities across our working groups.
Yeah, and the reduction of smoking, tobacco cessation efforts, along with monitoring cannabis utilization and providing support for those patients is one of our other ongoing initiatives.
So as Martha mentioned, this is just a small, this is just a subset of the many things that the working groups of the consortium as a whole have done. And I want to encourage particularly the physicians when we have our breakout to look at where we've been, look at where we are, and to pick your brain about ideas. In a perfect world, where would you like to see MROC go? And I think it would be great to kind of have just some brainstorming for where you see the needs for MROC going in the next 5 years. So kind of planting that seed for discussion to follow. Okay, so I guess I lose these two partners.
Yeah.
I get my other two partners back. So we'll switch. So the next portion of our meeting is to actually look at the individual working groups. And so we'll start with breast, and I have my friends back, my partners back, Frank and Alex. So look at first at performance and then at the 2025 goals or metrics. Okay, so this is the enrollment for breast by year. Obviously, only a couple months, not even quite that into 2025, but you can see in the past, 4 to 5 years, we're have exceeded 2,000, actually since 2019. The enrollment is quite impressive. And this shows the enrollment by facility. This is data as of the 25th of February. You can see yourself, what institution you are. And you can see that institution ZX is our overachiever, but quite robust number of breast patients. All right, so the 2024 breast quality measure. So everyone remembers this. We've had a 3-year initiative looking at regional nodal radiation. And we had a bit of a roadmap. In year 1, which was in 2022, as well as 23-24, we brought in TG 263 so that we could have uniformity in the naming of our structures. But with regard to training for 2022, we really focused on the superclav and the infraclav, level 3 of the axilla, to kind of focus on where those nodes are, and we had training sessions for how best to contour them. And then we went to 2023, where the dose metric was dosed to the superclav and infraclav, what we learned about in 2022. And then the training section went to the rest of the axilla, levels 1 and 2, and the IMN, the internal mammary nodes. So we had training. And then in 24, the dose metric was the dose to all of the nodes that were treated, the superclav, infraclav, and/or remaining axilla and the internal mammary nodes. They were all reported. Okay. And then the actual measure, here we have a 2-part measure. It's in node-positive breast cancer patients who were treated to the regional nodes. The nodal group was contoured and named per our 2G 263 naming convention. And then the dose was reported. And these were the points that were allocated to each level. And you can see that institutions did a stellar job. This was a 2-parter, and people generally met that and exceeded where we had the bar. So great job, everyone, for the performance on this metric. Well, all good things come to an end. And we've come to the end of our regional nodal radiation roadmap. But there's a lot more to do, and certainly the prone positioning that we spent time on. Alex did a great job this morning talking about it. We will continue to talk about it in the breast working group and take in your comments and learn about it as a consortium together. And then the other breast quality initiative was completion of arm measurements for lymphedema assessment. Okay, so the prone, again, this is a collaborative wide goal.
is to increase the utilization of prone positioning for breast cancer radiation treatment. As we mentioned many times, for full points, it's 30% or higher. But 30% is, we kept that at a modest level for all the reasons that you all said in your questions and more. We're all learning about how best to utilize prone positioning. Half points were if you utilize it in 20 to 29%, or as a consortium wide of breast cancer patients treated in the prone position, and 0 points if we as a consortium come in less than 20%. And this is where we are. So, and this is just early data, obviously. This is data as of the 25th of this month, so there's a lot more time to bring in data. So you'll see the denominators are quite small for those who have bars, and there's 0 in many other places. So there's a lot more that we need to do. But you can see that for patients who are appropriate candidates or who don't have exclusion criteria, because there are a lot of patients who are appropriate candidates who you may choose to do supine with motion management. But for those that you've chosen, you can see that our collaborative wide, we're right now at 49%. But there's a lot of growth, there's a lot of learning to do. So I'm really excited about this. Okay, lymphedema measurements for patients receiving regional radiation. And so just very quickly, the genesis of this is that we know that for patients who've had lymph node surgery and are getting lymph node irradiation, they're at risk for developing lymphedema related to their treatment. And so it is appropriate management for many institutions, including NCCN, that you actually measure them and you know where they are at the beginning, you know how they have done with radiation, so that you can send them as appropriate to our colleagues who can help them to manage, have interventions for lymphedema. So we thought it was appropriate to have a metric to show that we are doing just that we are assessing their lymphedema at presentation, and we're assessing it with treatment. So with that, it's to increase the baseline and post-radiation treatment completion rate of standard care arm measurements for lymphedema assessment in node-positive breast cancer patients treated to regional fields. And I'll say this is standard of care arm measurements, and I'll kind of put that in air quotes. There are very sophisticated ways to assess lymphedema. You can do volumetric assessments. We knew that a lot of places perhaps did not have that, and so we're doing it by way of arm measurements with a tape measure. So greater than or 50% or greater of breast patients treated to regional fields with the baseline measurement in 2024, they then have to have the follow-up measurement in Q1 through Q3 of 2025. So they have the baseline, they need to get the follow-up. B is that 50% or greater of breast patients treated regional fields with a start date within Q1 and Q3 of 2025 must have a baseline measurement. So we have to make sure that you get both. So full points if you get both A and B. So you've done the baseline in 24 and you're getting the follow-up in 25, or B, you're getting the baseline and the follow-up in 25. Partial points, either A or B, and 0, neither A nor B were met. Okay, next slide. And again, this is very early data. This is just part A, shows you where we are. These are the patients who had the baseline in 24 and you're getting the follow-up in 25. And the next one is those who are now in 25, and fewer patients because they're getting all their care in 25. So we will follow this over time. But again, the genesis of this was what we thought was best management of lymphedema according to published guidelines. Any comments, questions? Frank, Alex, did I leave out anything? No. Any questions from the group?
These are all.
Yeah, Melissa, are there any new questions from our members, or is everyone good with this?
I think we're good, and for the sake of time,
Yeah.
we will need to go forward. Oh, I take that back. There is one question, and perhaps you all should answer this. For those with experience treating prone patients, which positioning have you had success with in regards to the arm position? Both arms up or the crawl position?
Hello. Currently treating prone patients. Both arms up or crawl position?
See it, both arms up, yeah.
We only do both arms up.
Yeah, I don't know that we've ever had anything, at Michigan, it sounds like Frank is saying, where they've had their arms up, kind of like this way. I don't, so I'm not familiar with the crawl position. Or any other, it looks like other people, both arms up as well. Has anyone had experience with the crawl position? If not, we can maybe talk about the breast working group, but I'm not familiar with the crawl position, so we do arms up. Okay, all right, thanks. So I will now turn this over to Martha and Pete, who are going to talk about the lung working group. Thank you.
Oh, one more.
Oh, I'm sorry.
The,
Our next working group, sorry, will be March 27th. Please join us for the breast working group. It's the coolest group. Thank you. Okay, now I'll turn it over to Martha.
Thanks. Well, I'm back again. Melissa got me a new mouse for her office, so I feel like this is gonna be more successful than my weapon. Pete and I are going to present the lung quality improvement working group. So I'll probably run through the slides and then Pete, feel free to chime in as you have any comments. But at the sake of time, I would go ahead and get started. So today we're going to talk just about some quick working group status updates, and then we want to kind of plant some seeds for future planning. I know we don't have a lot of time right now, but I want people to start thinking about some ideas for future lung performance metrics and projects, because we will have a lung project working group coming up or retreat coming up. So we just submitted 3 Astro abstracts for lung. One of them was on dosimetric and clinical predictors for pulmonary hospitalizations. I think it is really great to see this data starting to come out as we've been collecting kind of these surrogate endpoints of cardiac and pulmonary hospitalizations for lung cancer patients, which I think is kind of a real world endpoint that has started to pop up in some other lung work as well. We also had an abstract on treatment interruptions and the impact on outcomes, and looking at variable fractionation strategy, so our SBRT and hypofractionation usage and impact on that. So we look forward to getting the results from these submissions. We also have 4 manuscripts in process. So, prior abstracts and prior projects that we're working on are moving forward to manuscripts. And so we're excited to have those moving through. So lung working group members will be on the lookout for paper reviews that will be coming up. All right, so let's jump into our lung enrollment. It's pretty incredible to see the number of lung patients that we've collected over the years. We're already at 114 patients for 2025. And we had almost 700 patients in 2024. So it was great to see that. And then you'll see that there was a jump when we started collecting hypofractionated and SBRT patients, and then the reduction of the small cell patients over time. This is where we are for 2025, so enrollment by facility. So already getting a great start. You'll see we have a variety of the number of patients across different institutions, based on, the number of lung patients that they're seeing and just their overall cloud. So kind of take a look at your site number on there. If you aren't sure what your site number is as we're going through these, feel free to send Maggie an email or MROQC support, and they can probably tell you your site number. And again, we'll be sending these out after them. So our lung working group quality measures, as many of you know, we are using the same measures this year as we did last year because they were new for us, and we will be planning new measures for next year. So for esophageal dose, we're looking to keep the mean dose below 29 gray and the D2CC under 61 gray. I love this measure because it comes from our own data. So if anybody is having any questions on this that may be new to MROC, please reach out. This is kind of where we were in 2024. The performance was really great, and we want to kind of continue on with that as we move into 2025. We don't have very much data in this measure yet, because obviously these are conventionally fractionated patients and they will have started in 2025. And so we only actually have one patient submitted yet, but meeting the measure, great job. Site EM. Our SBRT measure again is the same. This is the Paddock Conformity Index, which looks to have a very conformal dose distribution for lung SBRT. And the way that the Paddock Conformity Index is measured, again, it will make sure that that high dose prescription region actually is over the PTV. So if there's a mismatch of where that high dose region is in respect to the PTV or underdosing, overdosing, that will be reflected in this measure. So we have kept this one from 2024. These are the results from last year. Again, most sites did an excellent job. We have a few that we want to work with to kind of bring up. But overall, I think everyone did very well with this measure. And we did make some changes to this to give some buffer to really small PTVs, really low density PTVs, because it is hard for the planning systems to have a high resolution of the isodose volume that you need to compute this. So any questions on this, again, please reach out. And we do have some SBRT patients already submitted for 2025. And so everybody is doing good. If you have any questions for the measures, please feel free to throw them into the chat. But in the interest of time, I'm going to keep going for right now. So we want to do some future planning. So the goal is to kind of plant some seeds for what we want to do for 2026 measures. And this just highlights our lung quality measures over time. We've really had incredible progress in lung. We have looked at, motion management, lung GTV, PTV definition, TG263, standardization and nomenclature, minimizing dose to heart while maintaining target coverage. And then again, our annual follow-up measure so that we can actually have these abstracts and data coming out, for example, on the cardiac and pulmonary hospitalizations. And then this past year in 2025, going into esophageal dose and Paddock Conformity Index. So what is next? So these are a few of our current projects. We're looking at cardiac substructures. How important is it to look at dose there? Obviously, we're not going to put contouring cardiac substructures on all of our members unless there is really compelling data to do so. So we want to look at that data before we would move forward into any performance metric related to that. We want to continue to look at our cardiac and pulmonary hospitalizations and outcomes. We're looking at utility-based planning. So really what this means is planning to, maximize local control, minimize toxicity, not just focusing on kind of standard dose-based objectives. And so this is a project that, we've presented on previously in the working group meetings. We want to hopefully focus on the SBRT and especially hypofractionation. I think this is the one area that is very non-standard in lung, and there's a lot of guidance that can be gained from our consortium. So really focusing a bit on hypofrac guidelines. I know there are also some questions on ultracentral patients and what to do in that situation. And then, of course, we want to ensure that our tools that we're making are updated and utilized. And so talking about how we can increase that utilization, I think will be important. And what we want people to think about is outside the box, right? What can MROC do? Is there anything you're struggling with? How can the lung group provide value to our members and to your practice. And so we really want to talk about that within our upcoming working group retreat. And so that's going to be April 28th. And you can join us at MROC headquarters here in Ann Arbor or via Zoom. So we'll be sending out some more details about that. Our next working group meeting is March 17th, so everyone is welcome to join that. And then I'll just pop backwards a little bit to see if Pete wants to add anything, and also give people a chance to ask any questions or throw out any initial ideas for future projects for them.
Yeah, I would just add that the cardiac and pulmonary data that we get from those annual forms that we've been filling out for the past 2-3 years, whatever it is, we're just starting to get some data from that. So we're hoping to have more interesting data to share going forward and in the coming years. But in the meantime, we're really open to, what may be potential quality things for the next year or two, and any ideas that anybody has.
Thanks, Pete. And we will cover this in the physician breakout a little bit as well. People lead that discussion. Just one comment from Dr. Geyer, looking into hypofractionated regimens for central might be a great idea. Yeah, that is a wonderful future idea to look at. Thank you for
Yeah, and I would say one of the things that we were looking at going into this is, are people appropriately using fractionation for central? And that really has not been an issue. There's been very appropriate fractionation. I think the variability comes in those 5 to 20 or 6 to 20 fraction patients, those hypofrac patients, is kind of all over the place. But so far, there haven't been a lot of quality issues that we've seen with that.
Yeah, 100%. And, for those that aren't involved in the long working group, we've actually done quite a few like DICOM reviews for SBRT and hypofractionation, because we were looking for where we can provide value. And overall, I think the planning, especially for SBRT, has been very high quality across the consortium. We really haven't seen a lot of concern anywhere in kind of SBRT quality. It's really been variability in hypofractionation that we've seen on diagnosis. All right, I think we will go ahead and move forward. And so I'm happy to turn it over to Jim and Iyad and Lana to talk about both.
Morning, everyone. Thanks for joining us. I'm here with Lana, and we had Iyad there momentarily. I don't see him right now, but I'm sure he's still there. So what we're going to do briefly is just talk a little bit about our performance from last year, and then our goals for this coming year. And Lana and I are going to take turns commenting on different slides. So in terms of enrollment, this is just our data so far this year. Last year we were averaging around pretty similar, around 70 patients a month. And so this is 2 months worth of data. We're around 70 patients again. So very similar to what we've seen in the past in terms of enrollment. In terms of enrollment by facility, again, we've had sort of a skewed distribution for a while. And so that'll probably continue this year, but, have a lot of facilities that have already submitted some data for their bone metastasis patients, which is nice to see. In terms of our measures for 2024, sure people are familiar with this one, which was looking at shorter courses of treatment, where it was a 2-part measure. One was consortium-wide, looking at the use of single fraction radiation, and then a site-level component looking at the use of 5 or fewer fractions for all patients with bone metastases. And as far as a single fraction, component, again, just squeaking under the wire at exactly 45%, which was our goal. Some centers doing more than that, some less for these uncomplicated patients, but we met, the bottom line was we met our goal for the year. And then for all the bone metastasis patients with the 5 or fewer fractions per course, again, almost everyone, not everyone, but most centers met this portion of the measure as well.
This was our more physicsy measure for last year, which was for treatment of bone mets using SBRT. We wanted standardized dose constraints for OARs to be used, and any violations of those dose constraints are documented. And we wanted 80% or more of patients receiving SBRT to meet full criteria, and that was 10 points, and then less than that was 0 points. And overall, we sort of blew this out of the water, which is awesome. So this is going into maintenance for this year.
And so for 2025, we decided, and this is something that we talked about in the working group meetings for quite a while, really this idea of focusing on more on shorter courses of treatment, and whether that was, 1 or 3 or 2, or, especially with SBRT, so we decided to keep the portion of the measure focused on 5 or fewer fractions, also dropping the consortium-wide measure for the single fractions, because the breast group has a consortium-wide measure. And then the new measure is for focused on reirradiation, again, from more of a technical perspective. So again, this is very similar to what we had last year for the 5 or fewer fractions, all patients again, with a shooting for a threshold of 75%, but points as well for 60 to 74%. And this is how we're doing so far. So off to a good start. Obviously, small numbers of patients have been reported so far, but heading in the right direction.
And for our re-radiation measure, so for bone mets specifically, re-radiation cases, it's documented that physics was consulted before final physician approval of a plan for type 1 re-radiation or type 2 re-radiation. And this definition comes from an Estro publication. And so you get 8 points if more than 50% of these patients are documented of having a physics consult, and 0 points if it's less than 50%. And yay to the 2 sites that have done it. So good start.
And I guess we'll have a smaller denominator, right? Since this is just the re-irradiation cases, it'll be a fairly small denominator for this measure. So if anyone has any questions, Iyad, I don't know if you have anything you want to add.
Nope, you guys did great.
So I think we're a little behind on time, maybe. So if there aren't any other questions, just to let people know, we have a upcoming meeting, March 20th. We're happy to have people join us, give us input on, new areas we might want to explore. And with that, we'll just introduce Bob Dess and Dave Heimberger, who are going to update us now on the prostate working group activities.
All right, Dave, I have control of the slides, so you let me know when to go.
All right, and I think I'm unmuted. So welcome, everybody. We'll give a quick update. Bob, you can go to the next slide. So we're just going to go over the our current status update. I'll review some of the status of our 2024 metrics, and then Bob's going to jump into our 2025 metrics. Go on to the next slide. And the next one. So as far as enrollment goes, still very strong enrollment for this year. Obviously, everybody can look at their institution, and we have all but 3 sites now with some enrollment for the prostate program. Enrollment by year looks like on pace for last year. Last year was very successful, obviously, close to 1,200 patients and just the steady increase every single year. Next slide. We continue to work with music. There's some changes in how music reports their or how they're enrolling patients, but we're still targeting that match rate. So we're leveraging the data that's in the music database with our own and hanging in there at around 70% matching with the music data. Go to the next one. As far as our 2024 measures, just to refresh everybody, we had the first measure was the use of high-value radiotherapy in patients with intermediate risk disease, typically 28 fractions, or for those high-risk patients, a combo of external beam and brachytherapy monotherapy. And the good news is virtually everybody is meeting that measure. And that's going to move into maintenance phase for the coming years. So you can go to the next one. And one of the other measures was to look at or improving our long-term follow-up, since what we're really two of the things we're tracking are obviously biochemical control, but then also patient-reported outcomes. And a lot of those outcomes don't show up for years. We want to encourage follow-up, and we've got great compliance with our P6 completion rate at 12 months. And go to the next slide. This is going to move into a 24-month follow-up as a clinical performance measure. So that's where we stand for right now, and Bob will take care of the 2025.
I'll summarize a lot of work in a short amount of time. So we spent a large portion of the latter half of 23 and all of 24 preparing for 25, knowing that we would be revamping our measures for the prostate working group, and largely around improving our leveraging the known data from our randomized trials and translating that across the community to improve outcomes. The first one being hormonal therapy, particularly hormonal therapy in those men with high-risk disease, an intervention that's shown time after time to make men live longer, prevent the chances of the cancer spreading. And so we did a lot of work that was highlighted with some awards at our ASCO meetings, generating data that suggests that this was a good area to target because there was a lot of heterogeneity across the facilities in terms of the type of and duration of hormonal therapy used. And spent a lot of time designing new forms, which many of you have seen, to really understand the pre-existing comorbidities and patient experience and patient voice to make sure we were capturing that in a thoughtful way. And largely that has led to shooting for a 60% threshold for the highest number of points of men with high-risk prostate cancer getting an intended course, not the entire course, but an intended course of 18 months to 36 months of hormonal therapy. And so far, it's good to always see positive momentum in terms of people eligible for and meeting our newly developed measure, and we'll carefully watch exclusion criteria as well as reasons for not meeting that measure to make sure we're not missing an inclusion criteria. It's super important. And then also similar to take a page from the breast working group about a multi-stage process. As you might have remembered, we had a paper that also was highlighted in ASCO GU and our ASTRO meeting that showed there's quite a bit of variability in micro boost or focal boost of prostates, of specific lesions within a prostate. And not surprisingly, use of MRI was associated with an increased use of planar. You can't see it, you can't target it. And so you can't jump immediately to increasing rates of focal boost if you don't understand the tools that are required to deliver. And we started with, sometimes you need to do more to do better. And so we, same threshold, 60%, to look at men and patients getting MRI as part of their, within 12 months prior to their treatment course with prostate cancer. And thankfully, we've seen a great start to, again, for those eligible for meeting that metric, with some work to go and understanding the reasons why, and make sure we exclude people that are, claustrophobic or ineligible for MRI due to cardiac pacemaker or something. So perhaps a minute or two for questions. Otherwise, I try to preserve as much time as we can for last but certainly not least, MA Equal Group after me. Dave, any final comments before we pass the baton?
No, it's just been a great project. Like I said, want to give equal time to equal. Right?
Yes, yeah, I fully agree. And thank you for everybody's support. It definitely is, have big shoes to fill or big shoes to follow with all the other working groups that have been around for longer. So thanks for everybody's continued support. We'll see you in March. Mike, Elizabeth, Michelle, on to you.
Great, thanks, Bob and Dave. So I'm going to kick off this brief presentation on behalf of MEqual before passing the baton to Elizabeth and Michelle. Next slide. Yep. Okay. And so first I will talk about the cannabis quality measure, and progress toward our committee goals. And then like I said, Michelle and Elizabeth will kind of go through ongoing projects and looking forward. Next slide, please. Okay, next slide. Yep. So the cannabis education VBR measure we thought was kind of a nice natural segue from what MROC was able to do last year with the smoking cessation initiative. So we thought that with cannabis legalization over the last few years and kind of the information that is floating out there in the world, some correct, some incorrect. We thought that this was a very good opportunity for MROC to kind of help provide some education. We kind of thought about this long and hard, and we're trying to decide, is the message regarding cannabis use, is the message that providers want to send, is it the same across all patients who might be enrolled on MROC? And so when you take kind of the both ends of the spectrum, we decided probably not. So our thoughts as providers on this for a DCIS patient getting accelerated whole breast radiotherapy, that's probably a different recommendation for that patient, or a different conversation with that patient than the cachectic diffuse bone met patient who might also be enrolled in MROC. And so we were looking at the different groups, and we enroll probably the most breast cancer patients compared to the other groups with a long experience. And we thought that this would be a good group to kind of reach out to first. And so for 2025, the measure is that at least 50% of breast cancer patients who report using cannabis in the last 30 days, and this could be smoking, but then other types of use, oral and et cetera, are offered an MROC cannabis education document during treatment. Patients included are breast cancer patients beginning treatment January 1st of this year, and we wrap up September 30th. The document, hopefully everyone has had a chance to see it, but it kind of is an evidence-based document that outlines what we know, what we don't know, what's good, what's bad. I anecdotally have found this to be a very nice tool to open a kind of an honest and open conversation with my breast cancer patients that I truly probably wouldn't otherwise have had. So this is the measure for 2025. And again, we're aiming for at least 50% of marijuana users or cannabis users to be offered this document for education purposes. Next slide, please. It's still early days here, but this is the initial data as of February 25th, with some sites reporting and probably about 2/3 not reporting yet. And then lastly, if everyone can maybe take a brief moment to take out your phone and kind of capture this QR code. This will redirect you to a provider survey on cannabis for us to kind of try to get a baseline in terms of those folks in the clinic, whether nurses, physicians, therapists, et cetera, how often we're kind of having this conversation with patients and how we would characterize that. So thank you in advance for your participation in that survey. Perhaps you'll be able to do it during our break or after the meeting, but at least you can capture it now. And without further ado, I will turn it over to Elizabeth and Michelle.
Great, thank you. And that survey, I took it a little while ago, takes just a few minutes to complete on ways that we can help providers with cannabis. So Elizabeth and I also wanted to update everyone on our progress towards committee goals in the M-Equal committee. It centered to date around incorporation of additional social determinants of health elements for data capture, developing new quality measures from the quality improvement work to provide health equity sessions and self-guided learning for MROC members, to develop MROC's health equity mission statement and a roadmap that will guide for further quality improvement work. So leading us off in that category, so as far as incorporation of additional social determinants of health elements for data capture, that is an ongoing project with overall goal for patient demographics, screening tools, and educational sessions. We have started that, and there is a database update to integrate new forms in March of 2025, also with a plan next month for an educational session on the purpose and use of the new form. And then planning to develop new quality measures from existing QI work. So you heard a little bit from Dr. Dominello about the breast cannabis measure in that category to date. Dr. Cousins led a CDA breakout session last month on the MROC cannabis project for both CDAs and clinicians. I'll turn it over to Elizabeth.
Yes, so we also want to increase education and communication about health equity, do a series of educational documents. We're very open to feedback. If there are topics that you're interested in, please contact us and we can include that. Also with our upcoming live education sessions, if you have burning questions about health equity that you want us to address, we're happy to do that. We are also working on our mission statement, so focusing our work and what we want to focus on with our M-Equal committee. We want it to be focused around MROC's work, but also obviously include our health equity goal in this committee. And we want to engage with other CQIs that have health equity missions and see what they're doing so that we can be supportive and all have similar goals. One thing going in the future is that we really want feedback on QI initiatives. So we plan on attending different working group meetings, get feedback, share ideas. If you have interest in quality improvement projects, projects that circle around collection of demographic information or social drivers of health, then please let us know. We're going to try to pop in and get that feedback. But email us. We want to know what projects you're interested in for your body site so that when we're making these new forms, when we're collecting new data, that we're doing things that our groups are interested in that they want to focus on. Okay. That might be it. Any questions?
Turn it over to Melissa
For the Rockstar report.
So I'm the person today that gets to stand between you and being done with the meeting and the physician administrator breakout. So again, I will go fast, but I just want to announce that we're going to give the physicians and administrators just a little chance to stretch before we go into the breakout. And so if I can make it work, we'll start the breakout at 11:10. So without further ado. So I have a few things to go over with you this morning from the coordinating center, mainly to do things with data, website enhancements, our quality performance tools, and as it's already been alluded to, upcoming database update. And also, I want to highlight some quality award information. Mainly, one of the best parts of the February meeting for me is to give out the 2024 audit awards. And then we will talk briefly about the 2025 audit plan. All right, so website. We have been making some updates based on feedback and suggestions from the members. Hard to believe our website has been active officially a year today. And so we are very excited about that. But we've heard from you, you wanted some extra things. And so we've done some enhancements to the resources tab. And for those who haven't started using them, I will talk a little bit about our enhanced reports. And then just briefly about 2025 planned additions. And so the resource tab is one of the best places for you to go. And since our last meeting, we have revised the Blue Cross Blue Shield incentive program resources. So that's where you can find things in regard to pay for performance, gold card, CQI-VBR. And then we've also made a new section called treatment resources. And this contains information that will help support treatment planning at your facilities. And right now they're grouped under the working group that they're affiliated with. So there are breast resources, lung resources, bone mets resources, and M-equal resources. So I highly encourage you to check those out. Coming in 2025, we do plan to add an area for patient education resources. We are doing some work behind the scenes here at the Coordinating Center, working to make some patient-facing tools. And so we hope to have those ready and hopefully ability to roll those out by the May collaborative wide meeting. So look for those. One of the biggest things that we have done since our last meeting is all of the quality performance tools. Key updates that we want to share with you. So effective in January, the facility performance dashboard has replaced the monthly reports that were sent out previously. This is a very comprehensive dashboard that you can use to see things like enrollment, your performance on quality measures for the various incentive programs, and things like that. So that launched on January 29th. The comprehensive clinical and physics dashboards launched in February on the 6th and the 20th, respectively. It's been a really busy night. And these dashboards, one based on clinical data and the other based on physics dosimetry data, it's a one dashboard that replaces many reports. And for those who do abstraction, you know that you used to have to go into every single database, and we have 3 separate databases, to see where things might be missing or where you need to fix something. And so now this dashboard allows you to see a snapshot across all of the projects. We've heard positive feedback. We've had some office hours that have been hosted by our amazing analyst team that have built these dashboards and are maintaining them. And so I think those have been really helpful. We've gotten some great feedback. And there will be more of those office hours as needed. And then lastly, I did get one email this week asking, where is my report ahead of the collaborative wide meeting? So we had actually announced this at the October meeting, but it seems like a lot has happened since October. And we are now sunsetting that report that was coming out prior to the collaborative wide meeting. And we're going to move to a quarterly report that will actually be distributed at the end of every quarter. And so the first quarterly report is planned to be released in April, and it will include an interim pay for performance scorecard, as well as a quarterly snapshot for each quality performance measure, so you can see how your facility is performing compared to others in the collaborative. So look for that coming. And so again, if you go out to the website, you'll be able to see where these facility reports reside. And again, just as a reminder, the team is here. Should you have any questions, you can send, there's even a button for provide feedback. But otherwise, you can also send a ticket to support, and we will continue to host office hours as needed. Why? Because we're sunsetting the reports in the databases. So there have been messages going out to the abstractors as a warning. But I guess if you love those database reports, today is your last day to go look at them. Because effective on Monday, March 3rd, the reports that previously existed in the databases will no longer be available. We are totally moving over to the website-based reporting. And database updates. So the databases, all of them, will be down starting at 4 p.m. on March 7th through the 18th. Why? And why so long? We are actually doing some infrastructure upgrades back here at the coordinating center, that one of which we're hoping will help with, that annoying thing where the DICOM gets hung up. When you have over 40,000 patients in your registry, you kind of clog the servers. And so we're going to do some work there. And then we also will be adding in the social drivers of health data elements. They will be added across all MROC projects. So I know some messages have been going out to remind everyone, but 4 p.m. on March 7th, so next Friday, the databases will be down. We will let you know when we can go back. Quality audits. All right. This is, like I said, my favorite part. So 2024 audits. We had an amazing year, and we decided that we couldn't just do the top 3. We needed to do an honorable mention for 4th place with a score of 99.5%. So that's the overall combined score of clinical and physics. We had a 4-way tie. So Munson, My Michigan Medical Center Midland, University of Michigan Health, and University of Michigan Health West. Congratulations. Wow, those are amazing scores. So we had to give you points. So with a score of 99.55%, in 3rd place is McLaren Northern. With a score of 99.75, in 2nd place, we had Genesis Hurley. And in 1st place, with a score of 99.9%, in 1st place is Covenant. Congratulations to everyone. It speaks volumes of the high quality work that you are doing and the amazing data quality. We appreciate everything that you are doing for MROC and for your patients. All right. So in 2025, we have a little bit of a change. So in recognition of the high quality work that's been achieved by so many of our member facilities over the last few years, for facilities who had a score of 98% or greater on their 2024 clinical audit, or greater than or equal to 99% on their 2024 physics audit, you will be exempt from auditing in 2025. So we have 25 facilities. Anticipated number of audits for 2025, only 11 facilities will have clinical audits and 6 facilities will have physics. So I'm sure that if you haven't heard from them already, the clinical and physics teams will be reaching out to you to get those of you who need to have audits, get those started. And so I am going to leave questions. You may put them in the chat, but I do want to wrap us up so that we can move on to the physician and administrator breakout. Like I mentioned, I'm between you and the next thing. So thank you very much for attending today's webinar. I'm going to give full disclosure. We didn't think we were going to have enough content for this morning. And so we were like, we'll shorten the meeting. But I think it's been wonderful. I really appreciate everyone chiming in, asking questions, putting in comments. These meetings are for all of us. And so really appreciate everyone attending today. After today's meeting, you will receive a link to the MROC post-meeting feedback survey. Please take the survey. We do really pay attention to what you put in the survey. And one quick reminder, if you are attending in a group today, please send a ticket to support mroq.org with a list of attendees that are in your room. We know a couple of facilities are all sitting together. So that will help us out for attendance purposes. And boy, the slide was not fixed. So the physician administrator breakout will begin at 11:20. And we will be talking a little bit about physician engagement. And as Lori and others alluded to in the other part of the meeting, the state of MROC and the future directions that we want to go into, and hopefully some time for opening. Our next big meeting will be in person on Friday, May 16th. We will be meeting at the Kellogg Hotel and Conference Center in East Lansing. I promise I am not in Spartan Green today. I'm actually in M Eco Green, but you know, going back to my stomping grounds. And so check-in will begin at 9:30 in the morning, and the meeting will run from 10 to 3. Registration information will go out a month before the meeting. So we'll look forward to seeing you on May 16th in person. And so I cannot thank all of you enough. Thank you again for giving us your time this morning. Most importantly, we always want to thank our patients, our clinical champions, our administrators, our physicists and dosimetrists, our clinical data abstractors, our participating physicians. And, you know, I might have a bit of a bias, but the coordinating center, who I think is pretty awesome. And of course, our partners at Blue Cross Blue Shield for their ongoing support of MROC and all the work that we do. Thank you very much, and we will see you in May. Unless you are a physician and administrator, we'll see you in a few minutes.